Good afternoon and welcome to the 8th Plenary. I am Dr. J. Fonte, the head of the Pituitary and Adrenal Council of PSEDM. The post-operative management of patients with pituitary tumors remains a challenge. That's why today we are indeed grateful to have a luminary in the field of pituitary and integrative physiology. She is the director of the Pituitary, Adrenal, and Neuroendocrine Tumor Program of the University of Colorado, Anschutz Medical Campus, and the chief of endocrinology, Rocky Mountain Regional VA Medical Center in Colorado, USA. Colleagues, please join me in welcoming Professor Margaret Wierman.
Well, thank you. I want to thank the organizers for allowing me to participate in your Congress. I'm sorry I can't be there live, even virtually, since it's the middle of the night in Colorado. But I'm sure you're having a wonderful meeting, and I look forward to visiting you in person very soon. So as we know, hypopituitarism is a disorder that endocrinologists need to be thinking about and to not miss a diagnosis, especially after a surgical procedure. If you look at overall the incidence of hypopituitarism, it's somewhere between 12 and 42 new cases per year per million persons. There might be some data suggesting the prevalence is actually increasing. In a recent Spanish cohort of 29 to 45 patients per 100,000, perhaps related to the increased incidence of imaging and hormonal testing. Prevalence-wise, it's somewhere between 300 and 455 per million persons. And why do we care about it as endocrinologists? Because untreated hypopituitarism is associated with an increase in mortality, more in women actually than in men. And the question is why? Is it selection bias of historical controls? Are we doing a better job now? That's the question. So let's talk about a little background on the etiology. Remember that as the pediatric endocrinologists are going to see the children who have childhood onset due to genetic defects in the maturation of the pituitary development, and those can be isolated or with multiple hormone deficiencies or pituitary hypoplasia where the pituitary never develops. There can be perinatal or postnatal hypothalamic pituitary injury, or there can be tumors that happen in childhood or adolescence that we do think about. The craniopharyngiomas, the Rathke cleft cysts, or other tumors which require surgery. And then after that, the patient often has hypopituitarism. Importantly, any disorder in the brain which receives cranial irradiation from many other types of brain tumors can result in damage to the hypothalamic neurons and cause secondarily hypopituitarism. And then finally, infiltrative disorders happen as in the childhood and in the adult that can cause partial or complete hypopituitarism. So when we see the adult, again, we're thinking in the adolescent, we're thinking about the craniopharyngioma, the Rathke cleft cyst. We're going to focus today on the patients after surgery, after having surgery for a prolactinoma, for acromegaly, for Cushing's, and for the gonadotroph or non-functioning null cell tumors. We are seeing more cases of hypophysitis related to use of immunotherapy for different cancers, melanoma, renal cell, and other tumors. And we need to be aware of that. Sheehan syndrome in the postpartum hemorrhage, other types of infiltrative disorders, hemochromatosis can cause selective gonadotroph deficiency. And then again, cranial radiation in the adult. Secondary causes of partial or complete hypopituitarism we don't want to miss as induced by us. Medications, high-dose narcotics, especially the very strong ones like fentanyl and OxyContin. The patches can cause not only central ACTH deficiency, hypogonadism in males, and central TSH deficiency. People could be taking steroid creams, inhalers, and mood medications that may alter pituitary end organ function. So we know that the incidence of hypopituitarism post-surgery depends on the quality of the surgeon and the size of the tumor that is resected. But we have more specific data about the risk of hypopituitarism after radiation therapy. And here's an older a more recent study in almost 60 patients, 32 males, where they had standard radiation to the brain. And here you see for growth hormone deficiency, the incidence goes up with severe and partial growth hormone deficiency compared to those that don't have growth hormone deficiency. So we know that somewhere between as early as year 2, but as long as year 20 or 30, pituitary defects can occur, deficits can occur after cranial irradiation. So let's talk about each of the axes and what are the current standards of treatment for central defects. So obviously, this is a historical picture of one of the first patients who was treated with thyroid extract for primary hypothyroidism. But how is it different when instead of a primary thyroid defect and high TSH, we have partial or complete TSH deficiency from resection of a pituitary tumor or from radiation? So the current guidelines suggest that when you're treating somebody for central hypothyroidism, we don't follow the TSH. We follow the free T4 or the total T4, depending on which assay is better in your hospital. And the replacement is not to a TSH level, but to a free T4 or total T4, not even to the 1/2, but the upper third of the normal range. Now, the guidelines suggest if you have complete hypopit, this may be as high as 1.6 micrograms per kilogram, but in many cases, this is over replacement, and because patients have partial defects related to the tumor or radiation or the surgery. Importantly, it's an important clinical point to realize that those who have been given growth hormone therapy post-op, excuse me, may need more thyroid hormone therapy. In addition, the dose is adjusted based on sex, age, estrogen status, with the knowledge that we have of women who are estrogen deficient needing less thyroid hormone, and women who are on birth control pills, postmenopausal hormone therapy, or pregnancy needing their doses adjusted. Again, not based on the TSH, but on the free T4 or T4 level. There are comorbidities due to risk of both under and over replacement. We currently recommend against the use of T3 triiodothyronine or any formulations that combine of thyroid hormone by most of the guidelines. Well, what about the hypothalamic pituitary adrenal axis? We have CRH, we have ACTH production acting on the adrenal glands to make cortisol and DHEAS. What about complete or partial ACTH deficiency? It's the most common cause of adrenal insufficiency that we see in the clinic, either from exogenous sources or again, post-surgery or post-radiation. When we have ACTH deficiency, again, the important point is that it's not the same as Addison's, where both adrenal glands are destroyed by more than 95%. There isn't a complete lack of signal to the adrenals to make cortisol. Often it's just a partial. And if that's true, then the dose of glucocorticoids that we're going to give back needs to be partial. So if you're using hydrocortisone, historically we grew up with 20 in the morning and 10 in the afternoon. Now, more recently, we've shown that the guidelines suggest 10 in the morning and 5 in the late afternoon, given at 8 and 5. Some people give it at 3. The advantages are short half-life and theoretically more physiologic. But the problems we have, at least in the US, maybe you don't have, you have compliant patients. But if you miss a dose in the afternoon and you get sick, you have an increased risk of signs and symptoms of adrenal insufficiency, low cortisol. And at least in the United States, the cost of an ER visit is extreme. And so a lot of us are using long-acting glucocorticoids in lower doses, 2.5 of prednisone, taking in the morning with food. The advantages are a long half-life, steady level. Some have advocated using prednisolone if it's cheaper in your country. And then there have been several studies looking at a hydrocortisone slow release, trying to mimic the physiologic pattern of glucocorticoid secretion. But at least right now, I would say the jury is out on whether these really work. They either produce too little or too much in the Plenary, and then the chronocort that came giving 20 at 11 and 10 in the morning, and with an extremely high cost. And none of my colleagues are using these drugs here. Some of the people in Europe are using them. It'd be interesting to know if you are using them in your practice. Now, again, most patients after pituitary surgery either have normal ACTH cortisol dynamics or only partial adrenal insufficiency. So our goal is to decrease the exposure to too much glucocorticoid like hormones because of long-term risk. And these include osteoporosis, poor skin tone and healing, eventual insulin resistance and progression to diabetes, and question about long-term risk on the cardiovascular system. So whereas ACTH and cortisol deficiency is bad, too much is bad, and too little is bad as far as the adrenal axis goes. And so we always want to dose adjust to the individual patient and based on their signs and symptoms, and making sure that we pick the right dose and the right type of glucocorticoid replacement for their degree of ACTH deficiency. What about the growth hormone axis? So here, there's been a lot of studies about the role of growth hormone deficiency after pituitary surgery or with partial resection of pituitary tumors or after radiation. And again, it activates growth hormone, and we monitor the growth hormone action by IGF-1 levels in the adult. So in childhood, we can make the diagnosis of growth hormone deficiency with arginine, dopamine, glucagon, and they sometimes use IGF levels, whereas it's pretty hard to diagnose growth hormone deficiency in the adult, especially when the arginine GHRH test became unavailable. I think it's available in Europe. I don't think it's available in many other places. It's not available in the US. So we often use a low IGF-1 based on age and body weight, and it's low, and they're already on 3 other hormone replacements. So the predictive value of this is extremely high. GHRH arginine was the best test to insulin tolerance test. We don't tend to use the insulin tolerance test, at least in the US. It's not available, the GHRH arginine anymore. And so we've been forced to use a glucagon stimulation test. And again, it's a cumbersome test where we give either 1 or 1.5 milligrams of glucagon IM and measure growth hormone levels for 2 hours. Normative data is available for that. And macrolin was a growth hormone stimulator, a secretagogue that was recently formulated and available in the US, where you dissolve it in a packet in liquid. And it's one packet is good for BMIs less than 40. And we measure baseline growth hormone for a shorter period of time. Now, this is an exciting new advance, but at least right now in the United States, it's extremely expensive and not all the insurers are covering it. Now, our nomenclature or our normative data about what is growth hormone deficiency in the adult post-surgery has changed. And severe growth hormone deficiency is if the stimulated growth hormone is less than 2.8 or less than 1 if the patient is obese, because we have data showing that with obesity, the growth hormone response to these secretagogues is significantly less. Well, a lot of hypopit patients are obese, so it's hard to make that diagnosis. So we often, again, go back to the low IGF-1 with 3 other deficiencies. So who should we consider growth hormone therapy in the adult setting? If they have known hypothalamic or pituitary disease, they have the appropriate clinical context. We've optimized their other hormone deficiencies because, again, the risk of growth hormone deficiency increased to 100% if they have 3 to 4 of these other deficits. And we confirm biochemically that they have severe growth hormone deficiency. So again, our therapy depends on their age. There's increased sensitivity to growth hormone. You need a lower dose in older people. Gender, men need less than women. We usually start with a low dose at 0.15 to 0.3 milligrams per day at an evening subcutaneous injection. We monitor the response clinically and biochemically. And if there's no response, somewhere between 6 and 12 months, we stop it because the risk and benefit of growth hormone therapy in the adult setting still are somewhat controversial. We increase the dose slowly at 1 to 2 month intervals. So the best candidates have loss of other hormones, reproductive, thyroid, and adrenal. Why do we consider giving growth hormone? Because it can increase lean body mass, decrease fat mass, good for bone, and it might help their fatigue. It is costly, and there are limited long-term studies, but most of them suggest there's limited risk and some benefit. Our goal is to normalize IGF-1. We usually don't give it to people who have an active tumor. What's new on the horizon are new formulations of weekly versus daily growth hormone. And I don't know if any of you have been part of the studies, but we've been part of two of the studies on the weekly growth hormone. And I would say that our patients loved it, who were growth hormone deficient. They felt the benefit from it with a lot more ease and compliance and patient satisfaction. There was initially a thought of maybe giving the growth hormone in a tonic way versus pulses of it might have some end organ side effect or desensitization at target tissues, but to date, it looks very promising. Just a word about vasopressin deficiency. Most of our patients with pituitary surgery, if the surgeon is an expert surgeon at a pituitary center, do not have any trauma or damage to the posterior pituitary. That is seen with infiltrative diseases or metastasis. But if often in the postoperative period, there is transient diabetes insipidus. And again, in the anatomy, these are dependent on the supraoptic nucleus, which is near the stalk, and the PVN. And the ADH is used to control salt and water balance. They can't hold on to water. As I describe to my patients, you turn into a raisin and you have great thirst. And the treatment of it transiently is usually with DDAVP, either in the pill or the rhinal tube or the nasal spray. Now, during the postoperative period, we really often can then about 8 days, 5 to 8 days postoperative, see the syndrome of inappropriate ADH. And I don't know if you see it also in your postoperative patients, but in those cases, they're holding on to too much water and have a low sodium. So we currently send all of our patients home after their surgery on a 1500 cc fluid restriction until they have repeat sodium levels done a week after surgery. If their sodium is good, then we stop the restriction. Again, these are usually transient because pituitary tumors do not usually involve the neurohypophysis. Lastly, what about the hypothalamic pituitary gonadal axis, one of my favorite systems? We're talking about LH and FSH production acting at the ovary or the testis. So first in females, when we talk about hormone replacement in hypopit women, we talk about that they are recommended unless there's any contraindications such as clotting or perimenopause and risk for breast cancer. Importantly, remember that if they're given orally, which they usually are, they will alter growth hormone requirements and you may have to adjust your growth hormone therapies. In the premenopausal woman who has hypogonadotropic hypogonadism after pituitary surgery or radiation, we usually use an oral contraceptive with a less androgenic progestin, often about 30 micrograms, or you can go as low as 20 micrograms in an older woman. As the woman nears menopause, you can use oral estradiol in once or splitting the dose, or an estrogen patch and cyclic progestin in different dosing regimens, either with intermittent medroxyprogesterone, 12 days has been shown to protect the endometrium, or prometrium, natural progesterone, again for 12 days. We treat to the age of menopause to decrease the risk of cardiovascular disease, osteoporosis, and appropriate bone protection. Historically, women with hypopituitarism did not get treated, and that there's some data to suggest that that is why they had a more adverse cardiovascular and overall outcome than men. In the postmenopausal setting, we discuss the risks and benefits of estrogen therapy and progesterone in symptomatic women. We use the lowest dose to treat symptoms, usually with an estrogen patch, and it can be dosed starting at 0.05 and then dosed down with successive intervals. And then I think that most women should be on a cyclic progesterone. As the recent meta-analysis concerning the risk of breast cancer shows that if women's had her uterus removed, no progesterone is best for the breast. When you're giving estrogen, intermittent progesterone is better than continuous breast progesterone, which was used in the WHI. We taper the hormone therapy and we discontinue it as their symptoms abate. And remembering again that being on estrogen or being off estrogen, their thyroid hormone and their growth hormone therapies may need to be adjusted. One question about androgens or prohormones in women who have hypopituitarism. I was part of the Endocrine Society guideline and part of the international guidelines headed by Sue Davis from Australia, in which we reviewed the literature. And the data suggests in hypopituitarism, we recommend against the use of testosterone in women. And testosterone therapy, which is difficult to do because there are not FDA approved formulations in women, is recommended only for postmenopausal women with hypoactive sexual desire disorder with specific limited indications. The Endocrine Society guidelines also recommended against the use of DHEA in women with ACTH deficiency or in men with hypopituitarism because of the lack of data that supported bringing the levels into the normal range changed any hard outcome. Now, what about the male? What about testosterone therapy in the men with hypopituitarism? The data on testosterone therapy in just like estrogen for women in hypopituitarism is actually quite limited in contrast to all the data we have about primary hypogonadism or complete hypogonadism, hypogonadotropic hypogonadism. Various doses and regimens have been reported in all uncontrolled studies. Gonadotropin deficiency, again, may be partial. And what we do know is that testosterone therapy increases bone mineral density, but there's no fracture data. We know that if the patient is prepubertal, that if you give, that prepubertal testosterone levels have adverse effects long-term for the cardiovascular risk, but it's unclear what partial deficiency has long-term. And if you only have partial low testosterone and for how many years, and what is the impact of therapy? We know that testosterone is important for sexual function, for libido, for quality of life, for muscle mass, but all those changes are seen predominantly at pharmacological levels or high physiologic levels. In the Endocrine Society guidelines, testosterone therapy is recommended for hypopituitarism, but using physiologic doses, not too much, not too little. Importantly, we have to watch for the interactions of growth hormone and testosterone therapy on symptoms and signs of obstructive sleep apnea and insulin resistance, and dose adjusting may be necessary. Now, overall, how do we give testosterone in men? Testosterone now is available as a gel. It's available as a patch. It's available as an injection. There are pharmacological implants that are available. And very recently, there have been new formulations that are not hepatotoxic of testosterone orally, but it has to be given multiple times a day. Physiologic testosterone has been shown to improve energy, bone, and muscle mass. But if it's used at pharmacological dosing, especially if the injections are high and low predominantly, it increases the risk of polycythemia, especially in men with obstructive sleep apnea and enlarged prostate. And new data over the last 10 years supports the risk of high-dose testosterone in older men, so our hypopit men that are older, of heart attack and stroke in men over 55, especially when given injectable forms. So watch the dose, adjust it based on the comorbid conditions, and rule out obstructive sleep apnea, which should be treated before giving testosterone. It's very common in where I live in Colorado, where we have high altitude. You may not see it as much as I do, but it's a complicating factor every time we have to give testosterone. So lastly, what about preparing for fertility in patients with hypopituitarism? We do want to optimize their gonadal therapy. We want to use estrogen and progestin in women to prime the system, testosterone in males first. We want to optimize ACTH deficiency with the right dose of glucocorticoids, their thyroid. There's not really any good data to suggest that optimizing growth hormone is needed. In the KIMS database, women who went for induction of ovulation, either on their growth hormone or not taking their growth hormone, had similar outcomes. We definitely would like to control hyperprolactinemia if there's still a stalk effect after the surgical procedure. Remember again, the changes in thyroid hormone requirements on hormone therapy. This happens to be a small study in which they looked at the effects of just conjugated postmenopausal hormone therapy and showed what TSH levels did depending on their baseline. We usually see a 20 to up to a 50% change in thyroid hormone requirements with different doses of estrogen. And especially this is important if a woman is undergoing induction of ovulation with gonadotropins and even with clomiphene therapy. So we normalize the other hormones. We normalize the prolactin. If a dopamine agonist is needed, we give it. What's the optimal glucocorticoid replacement? These are patients that are ACTH deficient, and it's often partial. So either hydrocortisone or prednisone, there's no need for mineralocorticoid, and do not over-replace. That will impair fertility. There are case studies, again, on the growth hormone therapy, but there's no controlled prospective data, and we don't usually start somebody on growth hormone for fertility. And there's no data on the importance of vasopressin, but obviously controlling salt and water balance for fertility is critical. So what kind of data do we have in the literature about fertility in women with hypopituitarism? It's just really shocking how little data there are. There were, as of the late 2000s, 63 pregnancies and 48 women reported in the literature. It was a mixed population, most after pituitary lesion resected with variable hormone deficiencies. Most use a combination of human menopausal gonadotropins. Now we use recombinant FSH with HCG to stimulate ovulation. And they only got an ovulation rate of 60% on their treatment cycles. And they had a 40% miscarriage rate. Why? They had multiple gestations, hyperstimulation. The data is not really good. I think we're doing a lot better now, but there haven't been any large series reported. What about in men? We want to optimize their sex hormone replacement. We optimize their thyroid. We optimize their ACTH deficiency, normalize their prolactin. There's few data on the induction of spermatogenesis in hypopit men. Obviously, if they've already gone through puberty, you will surely, and their testis size is normal, you should only need a HCG effect, an LH-like effect. If they never went through puberty, you need both FSH and LH. So how do we do it? Here's some data from a study of 72 men who underwent 116 courses, and 24 of those men had pituitary disease rather than genetic forms of hypogonadotropic hypogonadism. They used HCG at a dose of 1,500, that's 3 times a week or twice a week, 2,000 for 3 to 6 months. And then they added recombinant FSH, Pergonal or Gonal F 3 times a week. That's either 1 or 2 ampules at 75 to 150 IUs. And they received, the outcomes were 38 pregnancies in this group. It's a mixed group because it's not all pituitary disease, but it was 50%. Time to spermatogenesis was 7 months, again, suggesting these men had gone through puberty before, so we just had to reprime the testis. The time to fertility was 28 months, so more than 2 years, and the average sperm count at fertility was 8 million. We don't have any much data about the female side of the equation in these kind of studies. Now, what they did look at, which I think is very useful, is again, the size of the response to the gonadotropins of, in increased spermatogenesis had a lot to do with the testicular volume and how the testicular volume improved if it was at baseline and increased with size or decreased. And that was whether they had never been on androgens or had been on androgens. So androgens alone tended to block that. And that's made some investigators, such as people like John Marshall, suggest that if you have a hypopit adolescent, once they become compliant with therapy, switch them from testosterone to HCG to keep priming the testis. So the time to response was predicted by a testicular volume greater than 20 mil sum and response at the second cycle and no prior androgen therapy. Does that mean we don't give androgen therapy? No, but it's something in the back of our mind to think about. Should we go to a 2 or 3 times a week HCG dosing versus giving testosterone to all our hypopit patients who haven't had their children yet? the males. So to summarize fertility options in hypopituitarism, we optimize their other hormones. We give adequate sex hormone priming of the axis, the steroids, and there's no need for growth hormone. In males, we probably need, and the females, if they're complete, we need FSH as well as LH. There may be a hypersensitivity of the gonadotropin therapies, especially in females, because they've already been primed, but also in males. And it's really unclear why there's such limited data about fertility in women, and the outcomes in women are so poor for successful pregnancy outcomes. We all feel that it's better than this, but again, since following up on hypopit patients for fertility is not in large quantities in any one center, there haven't been any large studies reported. The optimal strategy for males is still under investigation if they have a baseline small testis, whether to give a priming dose of FSH and then do LH, HCG, and then come back with FSH, or to just use LH alone. So in summary, hormonal deficiencies after surgery for hypopituitarism should be evaluated. The timing of the evaluation is usually between 2 and 6 weeks after the surgery, with a targeting especially of the cortisol deficiencies in the earlier time periods, and then adjusted appropriately based on the type of tumor or the degree of surgery or if radiation has been performed. We optimize thyroid hormone for the top third of the normal range. We optimize estrogen and progestin in women and testosterone in men. Cortisol, we give either hydrocortisone or prednisone, depending on compliance and availability of the different drugs. Growth hormone is the last to replace and depends on, again, cost and availability. For fertility, you need to give the pituitary hormones. Giving sex steroids will not induce fertility. Vasopressin, if the posterior pituitary is damaged after that transient abnormalities that occur post-op. But the take home, again, is too much is bad, too little is bad, and our goal is to get it just right. Thank you very much.
Okay, so with that, on behalf of the organizing committee of the Philippine Society of Endocrinology, Diabetes, and Metabolism, we would like to award you this certificate of appreciation. The certificate reads, the Philippine Society of Endocrinology, Diabetes, and Metabolism Incorporated awards the certificate of appreciation to Professor Margaret Wierman in grateful appreciation for graciously sharing valuable time and endeavor as speaker sharing the theme Hope, Help,